At the outset, I would like to welcome Dr. Viralreels, sir, who is an ophthalmic leader and who always inspires us to become an excellent surgeon and also to take the leadership position, whether it's RTH bill or whatever. You will always see Dr. Viralreels, sir. Thank you, sir, for coming to Kota, and my congratulations to after a long game. Congratulations, Dr. Ashok Meena, President KDOS, Dr. Sanjay Gupta, Secretary KDOS, Dr. Chandra, Dr. Jassi ma'am, and we are very fortunate to receive blessing of all the seniors, Dr. Kelal sir, Dr. Manthan sir, and Dr. Sudama sir. So many seniors are here. Always we receive their guidance and blessings, and it's great to see the residents, the young generation, coming forward, taking part in the active participation. So, as you know that the cataract surgery is the most commonly done surgery worldwide. If we talk about the data from the world, approximately 20 million surgeries done worldwide and 8 million surgery of cataract done in India itself every year. And we have witnessed the era of couching, and this is a video showing the couching where a small needle was used to dislocate the white cataract into the vitreous, and the ophthalmology matured cataract is being pushed into the vitreous, and this technique is still practiced in some remote part. Like for example, you can see this video where couching was done in this south of in the Africa continent, and the vision was restored immediately. But this vision was just only counting fingers, and this technique was associated with a lot of complications such as glaucoma, endophthalmitis, etc., etc. We have witnessed the extracapsular cataract surgery, the intraocular lens implant, and this was first done by Sir Harold Lindy at St. Thomas's Hospital. The surgery was done on 8 February 1950, and this changed the landscape, the practice of ophthalmology forever. This is the historical video clip of Sir Harold Lindy performing cataract surgery, and you can see the loop was used, and this is the one with which cataract knife was used to remove the cataract, and you can see the 6-0 sutures. At that time, there was no microscope, and there were no haptics. So many times these lenses were dislocated into the vitreous. Was done by Dr. Ridley. The refractive surprise was -14 because the power calculation that was done considering the air, not considering the impulse. So later on they revised the method of lens power calculation, and they addressed the refractive surprise. For young ophthalmologists who are learning phacoemulsification and IOL implantation, I would like to share with you that I have of the IOL was fiercely opposed by all the academic professors in that time, including Dr. Duke Elder, but Ridley persisted, and we were lucky that this device was accepted, and this changed the scenario of ophthalmology forever. Another most important invention was phacoemulsification, which was invented by Dr. Charles Kelman. And Dr. Charles Kelman applied for the Hartford Foundation grant, and he was approved $300,000 grant. He worked for 3 years, and so he was really depressed, and his hair was grown up. So he visited dentist that time to clean up his teeth, and the dentist was Larry Cohen. He was a dentist with interest in new technology, so he recently got this ultrasonic scaler. When Dr. Kelman visited him to get his teeth cleaned, he used this ultrasonic scaler to clean his teeth, and when he heard the high pitch sound and the vibration of emulsification, so emulsification, and the first case he did, it took 4 hours, and the ultrasonic time was 64 minutes. So now we are witnessing the era of innovation in the field of cataract surgery. We have femtosecond lasers. We have the devices to stain the capsule, the intracameral medication, the dye, the viscoelastic, the capsule tension ring, the femtosecond laser, nanopulse technology. So the cataract surgery has undergone tremendous advancements. Light adjustable lenses are also being marketed. We will have the facility to correct the retinal refractive error by adjusting the power of the lens. So this is one of the most fascinating area we have witnessed in the current era. So in addition to the tools and technology, the third important T is training. So I just produce the corneal interface cell loss, corneal decompression can occur, and then it's difficult to regain the vision without the corneal transplant surgery. So in order to maximize the outcomes in premium lens, we should always follow the principle of ABC: A, appropriate case selection; B, for the precise biometry and best possible surgery; C, for counseling, setting the right expectation, always under promise and over deliver; and C, for confidence management. So these are the ABC of maximizing the outcomes in the primary cataract case. Sometimes we are sitting like there are very high volume surgeons, like for example Dr. Veer does 40 or 50 cases in a season. And many times like patient come to us in the late afternoon and say, "Aaj sir, aaj hi karana, aaj hi kar do aapko, aaj hi surgery kar do." So sometimes we have been pushed to do the surgery. So never shortcut your examination, because in many times just retina examination, but many of carefully, especially white cataract. Even if you are doing the cataract surgery in post-capsular cataract, nuclear cataract, always see the retina, do the OCT, so that you can pick up any retina pathology such as ERM or macular hole by the OCT. So this is very important, and in order to see the importance of retina, we should always, because in these cases, if you miss any finding, it can lead to just share our advice. You must have heard this song. So we have tools